introduction. It's a delight to be here. Just some orientation pieces before we get going. If you can't hear me, just wave your hand and then I'll talk louder. Today's talk, it's going to last about 45 minutes to an hour. And then I really hope we have maybe 15, 20 minutes at the end for a discussion, because that's really important selfishly for my own learning. So I really want to know what you think. It's very important. The other thing is I brought a couple of handouts. They're not out because I find that people read the handouts and don't participate in the talk. The handouts there are two. One is sort of an overview of some cultural issues in Alzheimer's and dementia. The other is more of a focused review about a subject that I'm going to talk briefly about in the presentation. Behind me this is just it's a lovely painting. I like it. That's why I brought it. And I'm not going to talk about it, although I am. It's a Norval Morisseau painting. Norval is obviously a First Nations artist. Long story. We could spend weeks talking about just the painting. The cultural case that I am going to present is actually from a First Nations community, so I wanted to bring it just to enrich the talk. So we will just get started. And the purpose, and what I hope you get out of today, is really one. I mean, I hope you get lots, but I would really hope that you start to think about the brain and about culture in a slightly different way than you did when you came here. And we'll just get started. So, in the first 9 years of my practice, I was a family physician up in remote places in Canada for 7 years in a place called Moosonee Moose Factory. And this is from where the canoe is. That was the island that I was working on in a place called Moose Factory. And it was located in the area that you may or may not see. Oops, there it is. This is just a map of Ontario. You see Hudson's Bay comes down like this, and the bottom of it is James Bay. And there's a little tiny word at the bottom that says Moosonee. That was where the clinic was. And up, if you look on the map a little bit further north, this town is so small it didn't make it onto the map. So in between Moosonee and Attawapiskat, there's a little dot near where the river comes out into the map. That place is called Fort Albany. And I was there one day doing a geriatric clinic, and I was asked by a group of nurses at the nursing station to go see an elderly man there because there was some concern about he's having problems with his memory. And I said, okay. I went to go see him. Lovely man. This is Fort Albany. And what's interesting about Fort Albany is it's a very, very tiny reserve community of arguably about 600 to 800 people, depending on how you count. It is divided in two by a river, which you can see running through the town. In a particularly strange aspect of health policy in Canada, the town is on one side of the river, and all the health service provision aspects are on the other side of the river, which means when it floods, the road floods out, and people have to go back and forth, actually often by helicopter, which is very strange. The point is that it's quite remote, and it's all First Nations, all Cree. The gentleman who I spoke with only spoke Cree, and was unable to read or write in English or Cree or French or anything else. This is just a picture of one of the streets in the winter. Very small homes, often quite crowded. People will live maybe 6, 10 people to maybe a 2-bedroom home. Air quality is terrible. Plumbing is temperamental, and access to fresh water is a struggle. Fort Albany, and the reason why I'm presenting it today, is often when we think about dementia and cognition, we think about thinking. But when we think about cognition and thinking, we're actually really not thinking about cognition and thinking. We're thinking about people's previous educational experiences. And Fort Albany was the location of one of the most, well, at least if you live locally, infamous residential school experiences. The building that's on fire is the old residential school in Fort Albany. It's remarkable in the sense that it's built of concrete, like really concrete, like big blocks of concrete, in the middle of this quite idyllic forest. I'm not quite sure how they built it, but lots happened there that was absolutely terrible. Many stories are part of the local community that are not part of the general consciousness. And at one point, it was attempted to be destroyed. And what happened was people came up from southern Canada, they put explosives, they pushed the button, it went boom, and it didn't fall down. So they went away, and they came back and they did it again, they pushed it, it went boom, and it didn't fall down again. So people got quite upset, and one night it was lit on fire, and eventually it was dismantled and taken apart. This is an important part of the story, certainly because education, literacy, how people think about folks coming in and assessing how people read or write or think has a lot of historical, cultural, and power dynamic relationships. So when the hapless, wandering clinician is asked to go into a home to see someone about how they're thinking or their memory, that's not a benign kind of experience. Although it's quite lovely because you go and you spend time for a couple of hours and you get to sit with a gentleman who really doesn't quite get why you're there. He certainly didn't think he had a problem. The family didn't think there was an issue at all. And we'll talk more about that as the talk goes on. This is a photo in the public domain. I won't say her name only because that doesn't seem appropriate. Just to give you an idea how strange the North can be, this is the eldest survivor of residential schools in Canada. She still is alive. She actually happened to attend the school that I showed you. And she's on the phone with Stephen Harper, apologizing for residential schools, at least that's what it said in the newspaper. But what is absolutely wonderful about this photo is she thinks this is absolutely hilarious. She doesn't understand what the man is saying on the other end of the phone. She's surrounded by members of her family that just think, this is funny, some man from some other place is calling her. And her education was very strange in that she's fluent in Cree, she reads and writes. And Cree itself is an oral language. It was the text was actually sort of, as part of the missionary experience, people developed a syllabic writing system, which is another conversation. But she doesn't really speak English, she doesn't speak French, but she certainly could, for a time in her life, speak Latin and read Latin quite well, it's just very odd. Anyway, I show this picture because despite everything that's happened, the community certainly has also has a wonderful sense of humor, and she and her family, I know they thought this was just hilarious. So the case is of an elderly man living in a remote place, First Nations, Cree. Does he have some concerns about memory? Now for something completely different. Did you know this existed? There is an entire field called neural engineering. They have journals and they do stuff to your brain with, I don't know, technology. It's quite interesting. The picture that's on the front of this is of a network modeling. And I'm actually going to talk about it later on in the talk. It's a wonderful thing because the idea of networks, which is used in neural engineering, strangely enough, comes initially from sociology. And it comes from modeling of unemployment in the United States. Some people think it may have started with Milgram and psychology. It doesn't matter. It comes from the social science literature and have actually sort of migrated into the hard mathematical sciences and neurosciences. We'll come back to this, but it's a cool picture. This is not one of those Zen things, what is this sort of one-hand clapping? You and I, as I'm talking with you now, you can hear me talking. Hopefully the sounds that I'm making make sense, but there's something, you understand what I'm saying in some very basic sense. The reason you can understand what I'm saying is sound goes into your ear, it tickles the hair cells in the middle part of your ear, sound, that impulse goes down the auditory nerve, it then goes through something called the auditory association cortex, where sound is transformed into language, and then it kind of zips about the entire brain so that you can understand the content of what I mean. A lot of research actually has been done at the Hospital for Sick Children doing something completely different. People who, the point of this talk is to introduce some large concepts which hopefully will tickle your brain a little bit. Each of the little things I'm talking about is probably an entire PhD in itself. So bear with me as I gloss over some of this stuff. Okay? Cochlear implants are designed for people who have sensory neural hearing loss. And that can either be, you can either be born with that or it can be acquired as a result of illness. They're a device which has a couple of parts. One is this sort of thing that goes behind your ear, which is a receiver, and another little part that's the thing that looks stuck to the person's head that goes into there's a little hole in the skull that goes in, and it actually goes right to where the hair cells would be in the ear. Okay? Doesn't matter about the details for this talk. Okay? What's fascinating, and if you read the Journal of Neural Engineering, what the engineers are amazed about is, yes, they're excited about their engineering, but they're far, far, far more excited about the brain. When you hook up one of these little devices, either to a young person or an old person, you turn it on, the person does not hear language often. They may hear bits of language, it may, but I've been told it sounds a little bit, and over time, months to years, with training and learning, the individual will actually be able to hear language, so that this is transformed by the auditory association cortex, this intermediate part of the brain, into language. That's remarkable. Okay. And that gets us into thinking about the brain in a very, very, very different way. Let's take a look. Traditionally, when neuroscientists have thought about the brain, we've thought about it in two different ways. One, on where it says structure, we've divided up the brain into little chunks. And we've said, aha, this part of the brain does that, this part of the brain does this, and we've sort of broken it down. And that still very much is the way we think about things. A whole other way of thinking about it is looking at how different parts of the brain are connected to each other. And strangely, if you look at the history of neuroscience, both of these things have been prevalent for a very long time, and they kind of ebb and flow as to which one is the dominant paradigm that people are working at any one time. We're living in a neat time, is that they seem to be connecting. I took this picture off the internet only because it's a very beautiful picture, and it shows, it's taken with a particular technology called DTI, and it looks at the long tracts in the brain that connect different parts to each other. And I'm showing it to you because we usually don't think of the brain primarily as something that connects things. We think about it as little structural bits that each do their own thing. Why is that important? We'll see. The other thing, and I know you know this because you're lovely people, and everyone knows, is that the brain changes over time. And that the old dogmas that once you're born, you're kind of stuck with it, and then gradually things deteriorate is not quite true. This is a funny little picture that looks at essentially how the brain matures from age 5 to age 20. The point of it, the only thing I want to show you is that there's more blue when you're 20 than when you're 5. That's it. And that's what it's referring to is the degree of myelination, or the degree of fat that goes around the connecting pipes in the brain. And that it influences our higher thinking or our problem-solving capacity. So when folks say, oh, the teenagers don't know what they're doing, it's because their brain is not quite as developed. Although, all of us have met many adults who would sort of think, we're not quite there yet. So, colorful picture just to emphasize that change happens. Far more interesting from my perspective, because I look after the elderly, is that we now know there are actually two parts of the brain where there is new brain cells being formed up until the time that you die. And that is heretical. That is unbelievable. We would, if you would have said that 10, 15 years ago, I would have thought that I was crazy, and it just wouldn't make any sense. And the interesting thing is those two areas are, if you look at, on this little diagram, it really is supposed to be looking at the tan bits, in the hippocampus, which is the traditional memory structure of the brain that sort of helps lay down memory. And then interestingly, at the very front of the brain, somewhere called the entorhinal cortex. And we don't know what that means. I just raise it to say the brain does change. It continues to change over the course of one's life. Tantalizingly, we know that Alzheimer's dementia traditionally starts in the entorhinal cortex and then somehow involves the hippocampus. But again, new knowledge, very, very interesting. Thinking about culture in the brain depends on thinking about how the brain connects with itself. There are arguably 5 ways, and don't worry, I'm not going to talk about all of them except the last one a little bit. I just want to bring them to your attention. One way is through action potential, and all that is that's the mechanism by which electrical signals get transmitted through the brain. Another, and people talk about this all the time, is you have a whole bunch of chemicals floating around in your brain that help the different neurons to talk to each other. Those are neurotransmitters. That's what they do. They help things talk to each other. Although truly, what's actually important about neurotransmitters in the brain is not the neurotransmitter. It's about the distribution of the receptors that the neurotransmitter sticks to and where they're located in the brain. It's actually a complicated conversation, not for today. The other thing that's really, really important that folks in my field are really, really excited about is we've learned there's another type of chemical that we call neurotrophic factors. And these are chemicals that don't help cells communicate with each other, but what they do is they guide the growth of how the cells are connected with each other. So they kind of help direct where things go. They build the scaffolding that allows the brain to connect to each other. There's a new phenomenon that's only appeared in the literature really in the last 2 years, which is something called neural oscillations. And I'm only raising it, I just want to let people know there are many ways that the brain thinks and talks with itself that we kind of are just getting a handle on. Neural oscillations, I think of, is time in the brain. It kind of helps coordinate how everything unfolds in a way that makes sense. Because so much is going on, how do you know one thing happens before the other? So again, it's a whole conversation. What we're going to talk about today a little bit, because it ties into culture, is this idea that the brain is actually a place of networked information. And this actually is starting to be understood very, very concretely. The most dramatic example, which people seem to really understand, is that for some patients, and the example is that if you have a stroke involving the right side of your body, so you either had a blood clot or some bleeding and you can't move your right arm or your right leg, that's affected the left side of your brain. Classically, we thought that side of the brain that particular part of your brain had died, and really, you may make some minimal improvements, but you're not really going to improve. Okay? What we've learned is for some people, and it's not for everyone, but for some people, that's not what happens. For some people, the information that was stored in that part of the brain that allowed that right arm and leg to move actually moves. So the information actually moves from one place to another place, and it allows there to be rehabilitation, and it allows that right side, that right arm and leg to move. That's really, really interesting, because what it means is the function of that particular part of the brain is not necessarily intimately tied to the structure of the brain that we've classically thought to be. The language we use for this is that information, and this is not throughout the brain, but information in some parts of the brain is organized, forgive me, topologically rather than structurally. So it's organized in relation to it itself. That's really cool. We didn't think that happened. The neat thing is we know this actually is starting to happen in memory. There was a wonderful paper, it's so recent, from June of this year, by a neuropsychologist, Belleville in Quebec. And what she did is she looked at people who did not have any cognitive impairment. She looked at people who had some early changes associated with Alzheimer's, but not a lot. They didn't actually have Alzheimer's. And she gave each of them a whole bunch of memory training games. Okay. What she found is that the normal group, their part of the brain actually stayed kind of the same, and they were able to remember all the things. The group, the early Alzheimer's group, they actually were able to remember absolutely everything, so they looked the same on the testing after they had some brain training, however you want to think about it. But the areas of the brain that they used to remember were different. They actually recruited larger parts of the brain that were not traditionally associated with memory to perform their memory function. And it's fascinating because, again, it kind of challenges traditionally how we think about the brain works. The other thing, it was just so fascinating. I know we were just at a meeting last week in Montreal, and one of the basic researchers there, again from Quebec, did a very similar study, totally independently of Professor Belleville, and it actually showed the same thing. So that different parts of the brain are recruited differently in memory, depending on your baseline level of function. Fascinating stuff. Which brings me to the idea of a network. Okay? So, if you look at the yellow dots and think about the example I mentioned earlier about hearing, because I think it's the easiest way to understand what's going on. The yellow dots is the sound stimulus that's coming in. Okay? The blue dot is what the rest of your brain then understands. Like it's the output, it's the language that we use to communicate with each other. The middle part, for the green bits, think of that as the association area. That's the part of the brain that turned the noise that I'm making with my mouth into language which had meaning. Super duper important. And that place is where I would argue, sort of from a thought point of view, where we should stick culture in terms of understanding how the brain works. Although it's not as simple as being in the association area, and that's a whole other, that is also a bit of a larger conversation. And a wonderful example of this, actually, and it's funny because it goes back to the history of anthropology. And very shortly, I'll give you a definition of culture from a theorist called Clifford Geertz. And he famously said, culture is the difference between a wink and a twitch, which is so accurate. And the perfect example is among the Inuit. When I first arrived in Nunavut, you would do a medical history with an interpreter. People spoke Inuktitut. I didn't speak any Inuktitut. And I would ask people a question. Hello, hi, how are you? And then there would be silence. And I would say again, do you have any problems that you would like to talk about today? There would be silence. You know, the interpreter did the interpreting, and then there would be silence. And I didn't understand. And the reason I didn't understand is in the Inuit, when they say yes, they don't actually say yes. They just raise their eyebrows like this. And then when people say no, like this. So you can have a whole conversation one-sided without anyone knowing what's happening. And the person was going like this, like this, like this, like this. And that's very, very different than me having something in my eye and sort of, like that. And that's Geertz's idea of culture. Now, the example of hearing was a simple example to say that there is this part of the brain, the auditory association area, that makes sense of the sound that's coming in. The argument that I make in my seminar series is that culture is actually the association area of the brain, in the sense that all of how we think about the brain, memory, sensory input, what that input actually means is stored and understood as a result of previous experience. And what that input means is distributed widely across multiple domains in terms of interpreting sensory input, where memory is stored, how you've learned to walk, all these things. And one way of thinking about culture is that culture is the distributed memory of experience that happens to be sitting in your brain. Boy, let that dance around for a little bit. Okay, now back to some basics. In psychiatry, we have a tradition of attachment theory, which I really, really like because it's very, very relevant to talking about relationships with people. It's intuitively easy to understand at whatever place you come from when you're seeking assistance. And it's connected to, I think, how one can connect, well, how you can link culture and the brain. Classically, attachment is rooted in biology. Those horrible pictures of Professor Lorentz with being followed by the geese, you know, that's attachment. So, I mean, we don't think about geese, but in psychiatry, we think about it as a lasting psychological connectedness between human beings. And Bowlby is the fella in our field who really articulated this initially, and there's a whole group of other people, Mary Ainsworth, and that really did a lot of key work. This is a quote from one of his early papers, and I love it because it really gets it. If the attachment figure, so the parent type equivalent, it doesn't have to be a biological parent, it can be the person that's providing the care. And this has to be provided over time. It's not a one-shot thing, it's over years. Has acknowledged the infant's need for comfort and protection. Oh, it's so idealistic, makes you want to cry. While simultaneously respecting the infant's need for independent exploration of the environment, the child is likely to develop an internal working model of self as valued and reliable. Now, when I think about culture in the brain and I read this is culture in the brain. This is, and what's so fascinating about the attachment literature is the attachment literature was thinking about neuro and cognitive development in a relational sense. Traditionally in anthropology, culture has been thought of almost, I think this is a critique of it, of these ideas, and as sort of a reification, as something that you can kind of read a book. I will now read a book about Papua New Guinea culture, or whatever. I get my book, and I read the book, and I finish the book, I put the book down, and I know something about the culture of Papua New Guinea. And not everyone thinks that way. That's just a straw man argument for anthropology. But a lot of the theories are actually quite like that. So you think of something which can be understood in an intellectual fashion that allows you to decode the social situation that you happen to be in, which is very, very, very different than thinking about culture from an attachment perspective or a relational perspective, such that it's not so the longer that I lived in this factory, I was there for 7 years, and I thought I could decode things, I could understand. But the longer I was there, the more I realized I had no idea what was going on. And that was because what was important is, yes, it's very nice that you understand that when this happens, this is supposed to happen. But what was really, really important was that it wasn't about the knowledge, it was about the relationships that the individuals happened to have with each other in the context of living the experience that they were in. And that is really, really important, because the brain, as it develops and changes over time, does not do so because of, oh, I read a book and now my brain has changed. It does so because of the relational experience that someone has over time in a particular environment. One way of thinking about culture is sort of the recycling bin idea of culture, is everything you can think of that's important, you put it in and you close it and you call it culture. That's very helpful because it means it's everything, but it's not very helpful because it doesn't let you then think about everything. It just says, oh, well, it's everything. But it's nice because it gets you to think a little bit about, you know, in geriatrics, we think a lot about the norms of what a life lived means. We think a lot about loneliness. We think a lot about suffering. So when you actually explicitly include everything, it does challenge you to make sure that you've addressed the whole person. The way that Bowlby may approach culture, and one way of thinking and linking it to neurobiology, is linking it to what I've already said, relational learning over time with a particular context, and the content is delivered in a relational setting. This is the only way, I think, that you can link ideas about culture to the neurobiology about what's going on. Another way, and I bring this up because if you read anything in terms of medical anthropology or culture, you're going to come across Arthur Kleinman, who is a wonderful leader in our field. He's a medical anthropologist and a psychiatrist. And he originally came up with the idea that really there's illness, which is the social understanding of the person's state, so the interpretive meaning that they have with a particular way of thinking. And this is, I think, most appropriately explored actually in a couple of books by Susan Sontag, AIDS and its Metaphors, and Cancer, etc. And good. And then disease, the idea that, you know what, yes, it's really interesting how we interpret all these sorts of things, but if I have a heart attack, I have a heart attack and I'm not going to survive. Like that there is a biological bit, and that's, he says, there's the disease part as well. And the challenge of folks that are thinking creatively about this is to how do you blend some of these things together. Now, what I've just presented in terms of thinking about the brain and the environment is, it's not quite as easy as they're these two things, and they don't quite, they overlap. But that being said, I just want to introduce you to those ideas because it does help when you're dealing with a complicated subject to think, what am I actually thinking about? In terms of going back to our case, I just wanted to remind people about what the diagnosis of dementia actually is. And it's a bit confusing because lots of different bodies have their own ways of diagnosing dementia. And there are also lots of different kinds of dementia, which then clouds the picture even more. But my own experience is that it's not so much the details of is someone demented or not that's the issue. Like what kind of, I mean, yes, that's very interesting. It's interesting to us because it helps us think about things. But what's more important from my perspective is even getting to the point, acknowledging the fact that there may be something going on is often the more difficult thing. So in my world, in psychiatry, we think dementia is two things. One, it's an impairment in memory, fine, and one other cognitive domain. And the way it's defined for us is executive functioning, so problem solving, apraxia, this is movement, agnosia we think is naming, and aphasia we think is as sort of general language. And the other caveat is for dementia to have meaning, and it's even in our classification, there has to be some impairment of function. It has to somehow mean something to the individual or the context that they happen to be in. Which brings us a little bit back to Fort Albany. And the idea that there was concern about memory for this particular individual who, you know, it really is quite safe to say the nurses were really concerned about his ability to manage with his diabetic medication. And no matter what people did in terms of calling him, giving him blister packs, little ways of encouraging him to care for himself, it just didn't seem to be working. And unfortunately, the poor staff they're often so busy and so overworked that, to be frank, it's hard for them to leave the nursing station. Hi, come on in. No, please come on in. So, you know, I'm extraneous, so I was able to go visit someone. And when you go sit in the home, what you immediately realize is this gentleman, before you even think about asking him about his memory, is surrounded by his children, but also his grandchildren. He sits in the chair, and his function is to look after the grandchildren when other people are out doing things. And he is connected to that family quite well. He says he quite liked us coming by because we had a visitor, which was nice, you know. And he got to introduce me to his other members of the family and tell me about his life. And social preservation was very much there. I mean, he was a valued part of his community. Just so you know, and this is not part of this talk, there are some wonderful articles written by basic neuroscientists that challenge some of the ideas about how we organize the brain into cognitive domains. Because if you think about it, and the cautionary note is that, okay, there are a bunch of neuropsychologists or psychiatrists, and we think language function, we think executive functioning, we think being able to do a naming task is really important. All right, we will test for that. Fine. We actually don't test for, in a formal way, on a sort of cognitive test, how I relate to my son, or how you relate to your sister. And that, and this is not me, the loopy psychiatrist, but the hardcore neuroscientists will say, we have to be really careful that we're not mapping our own cognitive values onto this neutral object, the brain, and then somehow having it be reflected back at us. That's not to say it's not a valuable thing to do, because we do learn things, but that may reflect what we think is valuable. So, for example, it's very important if you live in downtown Toronto to know how to use an ATM machine. It makes no sense for someone in Fort Albany they've never seen an ATM machine. They would think that's magic or something. But what's very, very important is that this gentleman is able to care for his children in a reliable way. The other thing that's fascinating is that he lives in an environment where his village has not changed in 50 years. Those houses have been the same house. Even if he had no short-term memory, he would still know that Bessie lived next door. That's very, very, very important. Because if you go in as a clinician and you suddenly say, okay, you have an illness, you are disabled, that's a very, very different kind of act. All right. So the context of aging is also quite important. And again, we've talked a little bit about how we value things in our testing, and also how we see it. And the interesting thing, before I move on, is the neuroscientists will say, okay, yes, it's very interesting that we've tested this, but what are we actually not testing when we do some questions and we do some assessment of function? Are there things that we should add? Are there things that we should subtract? Interesting. So what I hope to introduce is, in the very broadest sense, in that early diagram where you had the network, there's an input layer, an intermediate layer, and an output layer. Culture, broadly defined, but defined as relational learning over time. There's this intermediate layer. And the fascinating thing about it, I don't know if you've picked it up in the course of this talk. Usually when people give this talk, they make this statement from a social science perspective. They make this argument, and it's a good argument to make. What I've tried to do in this talk is actually make this argument from the opposite direction, from the neuroscience perspective. And I think we actually both end up in the same place. Who knew there was a journal of neural engineering with a network derived from sociology and psychology on the very front of it? What do you see? How many people see a young woman? How many people see an old woman? Yeah. Why do we see what we see? So this is both an old woman and a young woman. And I hate these things because I can never see what I'm looking at. So just so that people know, oh dear, this is the mouth of the old woman. This is the eye of the old woman. This is the nose of the old woman. If you happen to see the young woman, this is the eye of the young woman. This is the neck, or the sort of the jawbone, the mandible of the old woman. This is her, the young woman, and this is her ear. Do people see that? Oh, it's so freaky. So, and that I think is an excellent example of how, you know, this is meaningless. This is just a collection of drawings and colors and all the rest of it. But what you actually see depends on something. Your occipital cortex, and then the meaning that's distributed across your brain, somehow has slotted it in one or those other things. And so that's just a nice little challenge. And this, again, is the caveat, how culture can come back and bite you in the ass, okay? When I first read about, I'm very naive. I don't have someone in my family who is hearing impaired. And I was approaching this as, gee, this is sort of an interesting thing from a neurobiological point of view. Gee, how fascinating. But then as I was reading more in the deaf community, and this is changing, this is a little bit of an older slide, but it just is again, how does this all fit into the larger context of a particular technological device and how it affects the brain? And so the idea is that before this comic is a happy deaf child using American Sign Language, member of the community, after an unhappy child, blah, blah, blah. And the point, this is just to say, there are people who think differently about this, and that's just how people think. And then even though I have given a sort of biological sense about the auditory association cortex is really fun and wonderful, that actually might not really be important to whatever is going on. Although I think it's fair, as I've read the literature, there is more of this type of work being done for children. But this is not my field. So, the argument that I've been trying to make in a broad-based way, because that's what this is a broad-based overview, is that the brain is an environmental organ. It's affected by the type of learning that we have over the course of our life. And by learning, I don't just mean like schoolbook learning. I mean, we learn very early on, or our brain adapts to an environment very early on if we don't have enough food, if we're exposed to violence, blah, blah, blah. And that carries on over the course of our life, even as we age. A concept that I want to leave you with, only because I think it's the single most valuable concept in geriatric psychiatry and in neuropsychiatry, and I brought a review paper along with me so you can all take one with you, is this idea of cognitive reserve. Because it can come up in every interaction that you have with someone as they age, whether or not you're healthy or disabled or ill or however you want to throw labels around, it doesn't matter. Cognitive reserve means that most of the time, at whatever age you are, we're moving along and we're using maybe, this is for argument's sake, 50% of our brain. Okay? I don't know if it's true, but regardless, we're not using everything, we're just trucking along fine at 50%. If I then do something to you, you may drink too much alcohol and you take away 10% of your brain capacity. It doesn't matter so much. You've still got a whole bunch of it there. If then, a few years later you develop diabetes and you have a small little silent stroke in another part of your brain, you're still trucking along at, 30%. It's okay, everything's still working. Maybe you then fall and hit your head. You're down to 10%. Oh. Then all of a sudden, your spouse dies. Everything falls apart. Whereas, if earlier on you just had the death of your spouse, you would have been able to pick yourself up and carry on. Cognitive reserve is the idea that often it's not one insult to the brain that leads to a change in function. It's an accumulated series of burdens that somehow will end up with some degree of disability. The reason I like this concept is it actually applies generally across mental illness. But secondly, it makes sense. Like, you can actually talk with people in your family or in your professional life, and people will get this. So there are a couple of more complications around this. You can read the article and use it or not. It's fine. This has been a bit of an overview of an approach to thinking about culture, an approach to thinking about the brain, and a little bit of grounding in a case. If you want shameless self-promotion, please come to my lecture series. The next one is on anxiety and perception. It's November 7th, and there's a handout that goes through when and where the rest of them are. The seminar series are organized much like today. What I do is there's a case, we review the neuroscience literature, we review the social science literature, and then we try and develop some sort of clinical synthesis that's useful. The next one is, again, on anxiety perception. Interestingly, for that particular topic, it's very sort of double-sided in that anxiety is probably the most biological of the issues that we can think of in terms of disability in the brain, but at the same time, it's probably also the most cultural of all the things that happen as we're approached. So I'm actually quite excited about it.
Is it
It's across the street at the Murray Street building.
Okay.
Yeah, there's a handout that has the address on it that I'll give. So this is the end of the talk. I've come to the end, and what I was hoping is that we could have just a discussion and see where we end up. So thank you so much for your attention. please, yes, you had your
I
hand.
just wondered why seminar in Asia was on the fourth floor.
Oh, yeah,
No,
What?
actually.
that's okay.
It's not his fault, it's our fault.
It's where the institute is.
Yeah. What I wanted to know is what sort of things would you recommend for readings for clinicians on this subject?
Oh, that's a good idea.
Michael, would you repeat the question
Oh,
so people can hear
sorry,
it?
so the question was what would I recommend for readings for clinicians? There are two things. One is, I have two handouts that I'm giving out today. One is just an overview of culture and dementia, and the other is on cognitive reserve. I didn't bring it today, although I have it. If you want, my email, I can give you my card after. I think my email's at the beginning of the talk. Let's see. I have actually bibliography for this talk, and I can email it to you. And it's a list of both basic articles in neuroscience that are more general and accessible, and a list of articles in the social sciences which are accessible.
Good, thank you.
So I can get that to you. Yes, please.
Just two quickies. What about nanotechnology? Are you involved in that in your work?
No.
No.
These people are, ironically.
Yeah, I was thinking of that, yeah. And
Yes, but let me finish about that. So, you know what? One thing, and the reason why I'm doing this seminar series for me is that the acceleration of learning in both the basic neurosciences, in the social sciences, and in technology is incredible.
Mhm.
And I found that I finished my training, I sort of had been practicing for a little while, and I was really, you know what, I don't know how to work with people because there's so much going on,
Yeah.
and the knowledge that I've attained in my formal training is about 25 years behind. As an example of where things are going, so in this, I've talked a lot about cochlear implants. People are actually doing work, strangely in Australia and then also in the United States, about developing ocular implants. So an artificial eye, based on the same type of technology where there's some sort of visual input going into the ocular nerve, and again, using the occipital cortex and association areas. And I only say that because when I read these articles, I feel like I'm reading science fiction. And what, again, is so fascinating for me, as I come from more of the biology and the brain point of view, is the scientists are more interested in the brain than they necessarily are in their technology, although there are lots of wonderful technological problems. So I must say I can't speak to nanotechnology because I just don't know.
And the other question, can I?
Yes, please, yeah.
I'm thinking of a neighbor. What would be the long-term effects on a severe inflammatory disease that, thinking of my neighbor who has like a lupus, and I noticed that she'll be talking, she's very bright and very informed, and all of a sudden, oh, where was I going? That in part seems to be a momentary thing, but I'm wondering, can it, on a long-term basis, from the point of view of a well-established inflammatory disease, lead eventually to permanent memory loss?
So there are two things about that question which are really interesting. The first is everybody's very different, and your friend would have to go get assessed in the appropriate context. That's sort of one thing. The second is that inflammation, as we learn about the brain, is really important. And there are general changes that happen. And particularly with lupus, we know there are some changes in the brain that happen. So that there may very well be some cognitive or brain component to what's going on. The other thing, though, is often, unfortunately, the medications that are used to treat anti-inflammatory diseases in themselves have their own host of side effects that unfortunately can affect the brain as well. So I think what you'd have to do is just have her be assessed in an appropriate context. Sorry, yes?
So I think you've confirmed today that one of those things that I've always believed is that you take the girl out of the country, but you can't take the country out of the girl.
Mm-hmm.
And that's the idea about culture affecting someone's brain and how they think and how they interpret things, or what the output would be. Is it possible to have two separate cultural filters or cultural mechanisms to interpret information, and that they could be used simultaneously or that they would be used only at certain times.
So I think the first thing is I think one hard thing about thinking about this area is that the word culture is really confusing as a word, just period. So it can mean a whole bunch of different things. Perhaps the simplest way to answer your question is to think just about language, because there actually is research about people speaking multiple languages, and bilingualism is an area of research for neuroscientists. And people can speak more than one language, obviously. People can be affected in terms of the content of how they see the world, partly through language, and there's some interesting research been around for quite a long time thinking about that. In the same way that the picture of the old woman and the young woman is both the old woman and the young woman, I think that can mean different things. But what I must say, when I talk about culture, I'm not actually meaning so much about language or what particular ethnic group you're from, or what I mean is, I think what I would argue more slow, more long-term kind of things that happen as your brain develops and continues to change over time. And so I understand what you mean. Can people live in more than one culture? Yes, I think that's true. Does that kind of affect some deeper part of how we are as people? I don't know. There is a whole interesting literature that is talking about bicultural people or multicultural, or in terms of does that affect how we think? But it's so nascent.
To bring back to the practical,
Yeah.
in practice, I was working in a long-term care home, someone who lived through the war,
Yes.
and then someone who's been post-war, had those two different sets of ideas with how they would respond to life.
Very much.
And so at the end of their life, which one are they using? And sometimes they would refer back to panic and responding to the environment when they were in war. And other times they wouldn't be. So I was just wondering.
I think that's fine. I'm glad you brought that up, because I'm always amazed that as you care for elderly people, particularly those who have had war experiences, and in the context of their family experience, you know, they've kind of held it together for their entire life, and then somehow they develop a degree of dementia, and then all of a sudden, I think, they present with post-traumatic stress disorder as a result of being unable to modulate those experiences. And that's a classic example of this cognitive reserve idea. And also how different people may experience the same event totally differently. So that, you know, there's a large literature in post-traumatic stress disorder such that it's not actually the threat or the assault or the violence, the war or the rape that leads someone to a post-traumatic stress disorder. It's the person, and that people, a certain percentage of people will go on to develop post-traumatic stress disorder. And that's really, really interesting. You know, how do we support resiliency and allow people to cope? Yeah, Soraya, for yourself.
What I found very interesting in your talk is I'm a specialist in elder care consulting. I have a small business that
Great.
helps adult children manage aging parents. And we often get clients who need capacity assessments because one is wondering how well they can function. And you've put a whole new dimension on this, and I think that everybody who is doing a capacity assessment should be listening to your lecture, because the relationship to the family from the reality point of view is quite different from the capacity assessor's point of view, and people may be deemed much more cognitively impaired than they really are at a functioning level. And that is what really impressed me most of all today.
Yeah, capacity is such an interesting issue. My own bias is I actually don't think we think about it nearly enough in medical settings. But thank you.
I'm just going to tell you a brief. I went to see a 92-year-old man yesterday at the request of a bank. And I went there and I saw him. He was delightful and he was really functioning okay. His wife died 10 years ago. But they felt that it was time that he should move into a retirement home. And I agree. And I think in a retirement home, he would be perfect. He would be delightful. When I got to the bank manager's office, she had received a letter from the public guardian and trustee because a Form 1 had been done on him. And I thought, how sad this is, because now everything is going to go on stop because we can't get a hold of the assessor, we can't get a hold of the trust officer, and this man is going to languish all through the winter because nobody's going to do anything because the PGT's office is involved. And I think that is so sad.
You know, it's a big issue. It is. Sorry, yourself.
When you were talking about people who've been through the war and then people with dementia then experiencing PTSD, do you have any idea how someone at that point, if they're quite demented, would experience it?
Yeah.
How would you know it, and what would they be experiencing?
Well, I think, so classically, it depends what kind of dementia you're experiencing, but classically, dementia affects short-term memory first, so the long-term memories are preserved. Often, people, I think, go through life quite well using the front part of their brain to problem solve their way out of difficult emotional experiences. And as you lose that capacity, I think you can be flooded by emotional experiences that you then no longer can cope with.
Do you have any sense of how people who, it's kind of a really weird question, people who have a dementia, what they're actually experiencing?
I always try and ask, and I think that's the most important thing, because I may think that they have this experience and they may be telling me about something completely different. But to sit down and ask will be so, so important. Because what's important, I think, is not even the content about what they say or what someone says, but that they have experienced the relational moment of you being with them and expressing care and then having them communicate. And that's, however you want to think about the treatment of post-traumatic stress disorder, the very first thing that you need to do, whatever pharmacological agents you use, is have safety. And safety is in the context of an interpersonal experience.
If they're able to have that?
Yes, if they are, yeah. But I think not assuming that, I think social interaction and the skills to engage relatedly with people is often the very, very last thing to deteriorate in most dementing processes. I mean, that's a gross overrealization, but it can happen. Sorry, Dr. Goldens.
Yeah, I think an even commoner thing than PTSD in clinical practice is presenting with a chronic pain syndrome. And these are the people who just have lost a little bit of executive function. So their need now is intolerable because they can't put in the greater scheme of things. Yes, I can still go shopping, I can still play with my grandchildren. I think it's a very similar thing when they present with that chronic pain syndrome, even though as a physician you can't find anything has changed from 2 years ago.
Completely. And that's such a good point, because there was, I don't have the reference, but there was an article this year in the BMJ that talked about treating people in long-term care to reduce agitation and aggression, and they found by having an organized approach to pain, they reduced the experience of agitation and anxiety by somewhere like 40 or 50%. Very good point, thank you.
I would like to know, there was a TV program on 2 weeks ago, and they said, and I was appalled, that geriatricians are the lowest paid of specialists. Why is that?
It's
And
not
it was
true.
so desperately
It's actually not true. So that if you, he is the former president of the Canadian Geriatric Society, so there have been a lot of changes in the fee schedule. Actually, psychiatrists tended to be lower than geriatricians, even at the worst time for geriatricians, no offense. And pediatricians are the lowest, currently, I think, among the specialists. Because their special billing privileges have been taken away, so they're paid the same as family doctors for their specialties. I think the problem is not paying doctors. The problem is how we pay doctors. So there's a hierarchy of what we value in society. And places where geriatrics has really flourished is not where they pay geriatricians more, is where they pay geriatricians the same. That means different than fee-for-service payment. And I think that the whole structure of our payment system would have to change. Speaking of that, though, we have unbelievable, in the last 4 or 5 years, an unbelievable number of outstanding people applying to our program in geriatric medicine at U of T.
Oh,
And at
you
one
better
point, we
write
had
to the
11 people at one
BBC.
time.
You better write to the CBC.
Please, yes.
Correct them.
Thank you for the talk. My thoughts go to the fact that my father died at 98 and my mother was 94. And I did work with several seniors in homes. They had a form of dementia, but they were really afraid to admit it. And they were, like, even my mother, she was holding it back and she didn't want anybody to know. And my mother was Canadian, my father was Russian. And when I took him to be tested, and culture is what brought me to this, is that the two people that did test him had no idea that the answers that were coming from him were from Europe. And his thoughts were from Europe, and his answers, and I was sitting there listening and saying, but this is his perception of what you're asking. And we had very disturbing experiences because one family would say, yes, he's not, and yes, he is, and then I had to bring people in to spend days and say, please tell me the truth, because in my mind, this man can sit there, and if you tell him about numbers and figures, he can say, you're wrong. So I came here because at that point I was very disillusioned in what is really happening. And as I am 70 and up there now, and maybe need something to do for the next 30 years if I live that long, I need to sort out what is happening on your side, on her side, and the side of do they know, do they study where these people are really coming from?
Yeah.
So I was impressed that you went up there to the crease and you were looking at that.
There
Thank you.
are, no, it's very, I really enjoy your points, and it's a very good, I'm sorry about your experience in terms of having people assessed in that, because one of my areas of interest is actually cognitive assessment. How do we actually assess people from all sorts of different contexts? And there are actually a number of ways of doing it. There are some tests that are a little bit less biased, if you will, in certain ways. But I think, your experience is, I think, actually quite common.
Unfortunately.
So that, because the norms that are all the tests that are used in memory clinics, by and large, are developed in particular populations, and the norms that they use to evaluate people are actually very, very specific. And they are relevant only, full stop, only, in a comparable population to which they develop the norms for. And neuropsychologists, so classically trained neuropsychologists, are excellent at this. They will say, no, we can't do this test because the population that we're doing the test is not the population that is the, and they're very, very good. Unfortunately, there are not very many neuropsychologists around, and most of the testing is done in different contexts. But there are some instruments that people can use, and particularly in, how do you assess cognition in people who are functionally illiterate? How do you assess cognition in people who have English as a third language or who don't speak? How do you assess cognition through an interpreter? I think there are some ways of doing that, but they have to be done thoughtfully, and it takes a very long time. Not to plug my seminar series, but there is one of the talks near the end, I think the second to last talk is on dementia, cognition, and value, and I'm actually going to bring in some cognitive tests that are slightly different. There's one that I particularly like to use that was developed in Europe, but it's been used a lot in South America and also a little bit in Asia, and it's not a pen and paper test. It actually is it's sort of a memory test with pictures, and then there's some numbers and blocks that people use So there are other ways of doing it, very, very difficult to access. Thank you. Yes, please. Yeah.
Just an online question. Cassie wants to know if she may have the title of the journal you'll be posting, the review that you discussed about.
Oh, about pain or about cognitive
Well, you had
reserve?
mentioned two, and some viewers would like to know how and if that would be made available to them.
Oh, sure. Maybe what I could do is send them to Susan,
We can scan them.
and then people can contact the Institute, and then it can be
Perfect.
sent around.
Okay, thank
Yeah.
you.
Thank you.
Talk about the difference in culture for cognitive testing. You can't agree in downtown Toronto to North York about what tests should be used, let alone over different countries. At least from different countries, the cultural context clearly makes sense that you couldn't agree.
Yeah.
But from downtown to midtown, you can't agree, so you can see the complexity of it.
How unfortunate.
And one thing that is, I should have mentioned this in answering your question, and this is not ideal, but it should be part of the assessment, is there is a small literature about assessing dementia just on the basis of activities of daily living. And I think it's very, very informative. I like it. The problem with it is usually the people who are telling you the information are the people who may have their own agenda of what they'd like to have happen with their loved one. But if you can get reasonable information, it can be very helpful, because ultimately, is the person safe to live in the environment that they're living in, regardless of their cognitive scoring? That's important information. So just to
The gold standard is sometimes sending an expert into an occupational
Exactly.
therapist into the home to observe them doing their daily functions, and that's, because even a kitchen set up in a hospital could be different from the one they have at home, and you can't really decide.
Well, at 98, my father threw someone out because he said you do not wash the floor with the dishes, the cloth that you wash the dishes. And he said, get out. So he knew, what bothered me, they're all dead now, so the problem is finished, but what bothered me is that if there were 10 people highly educated in the field, everyone had a different opinion and everyone had something else to say. And as a daughter sitting and having to take care of all this, and I said, and knew nothing about it, it was really disconcerting to have to go through that and to deal with it.
And just to give you an idea, because how there is so much uncertainty when we think about the basic neuroscience of the brain. In MRI, which is one of the ways that we commonly use to assess different parts of the brain, there are large debates about exactly what little part of the brain are you actually looking at when you're looking at that little part of the brain. So people in technical meetings will actually get quite heated about, really, we're looking at this? No, we're looking at that. Does everyone look at this? And does everyone look at that? And it's some of the basics is really difficult to sort out, because the other thing that is profound is that there's individual variation from person to person. And it's not just with the brain. If you talk to any surgeon, when you look at things about the anatomical distribution of arteries to the heart, for most people, they look like 80% of people will have it the way you say in a textbook. But then there are known variations about, well, this artery actually goes here, this one goes here, sometimes there are two. So in something as, forgive me, simple as the heart, there's variation. And then you think about a complicated structure like the brain, which even, and this is what I think is so fascinating about the topology, that even in places that we think this is just what the brain does, it can be challenged, and actually another part of the brain can do that. So it really is challenging, I think, how we understand some of the very, very basic biology. But I feel for your experience, because it's very, very, very frustrating to have all these different people disagreeing about the fundamental things going on with your loved one.
I knew that he was okay, but I'm just an actress, singer, or whatever, I'm not in that. And it was extremely difficult, for him at the end of his years, because if he was able to go, like you said, you tested them and they were winking and whatever, if he could answer like that, he'd be terrific. He would give all the right answers,
That's right.
you know, but it's very interesting. Thank you for your talk, it was wonderful.
Yes, it was excellent.
Sorry, I have 2 more questions, and I don't know what the time is. Perhaps yourself?
There's another online question, and they ask, is there a reliable instrument that trains the brain for maintaining memories?
The short answer is no. That's also the long answer. The trick about that, and I mean this is a controversial area, people say different things about it all the time, so it's changing. How we think about this may change. My own thought is that if you do, as an example, Sudoku or brain teasers or whatever, I think you can become very, very good at doing Sudoku and brain teasers, but that may not translate into activities in your life that may be useful. But there is, if people are interested in this, I actually would recommend that you go to the Baycrest website, Baycrest Hospital for Geriatric Care, and there's some more information there. Although they have a very particular opinion about how that should go. Sorry, one more question and then we'll...
Well, it's just some information or a comment in that I took part in the test that's going on at this moment at Baycrest Rotman School, where they're using computers, and they have a group of people who are doing the test without training and a group that are doing it with training, and I happen to be the one without it. But soon they will be putting on their website what games do work with training. The other thing that I just wanted to mention, and again it's totally unrelated, and that is Norman Deutsch that wrote the book Mind That Changes Itself, or whatever it was. His brother actually has a tropical vaccination clinic on, it's on Queen Street, Broadview and Queen, and he has all this artwork up, and the beautiful pictures you showed us. His brother has altered them and uses them as pieces of art, and they're fabulous.
Thank you.
Can I just say something? This morning on CNN, there was a gentleman from England who was talking about experiments that they did on mice who grow old very quickly. And apparently he was absolutely astounded, and it's a fabulous new thing that's happening, that the next generation, I suppose, will not be faceless. They will be able to be young forever. And apparently this is a new thing that just came out this morning as I was walking out and I listened to it. And he says, whether there's going to be some repercussions on this new experiment that was so successful, we don't know. I said, hello, okay.
Yeah, a general comment about that is, I would be really cautious about thinking about that. And as an example, you know, I think about 15 years ago, I think folks in the field were very excited about the amyloid hypothesis for thinking about Alzheimer's disease. I went to conferences where it was almost like a religious experience. You know, we will find the cure for Alzheimer's. And they were good. They were good meetings. It's obviously much, much, much more complicated than that. And one of the unfortunate things about this type of research is we don't know what we don't know. That's such a caveat, just to put that out there. But thank you very much. I've really enjoyed the discussion. It's been very helpful.